Hello everyone. Myself Dr. RACHANA, Associate Professor in the Department of ENT at Reddy Medical College for Women's in Hyderabad. In today's learning session, I shall enlighten you all about acute suppurative otitis media, in short ASOM, one of the most commonest ear infections seen in pediatric age group. So, the objectives of this learning session are to define ASOM, to enlist at least four causative organisms of ASOM, describe the five stages of ASOM, explain the management of ASOM, and to identify and demonstrate the clinical features of ASOM in the patient. So, coming to the definition of ASOM, it is defined as the acute purulent inflammation of the mucoperiosteum of the middle ear cleft by pyogenic organisms. So, it is the acute, that is, duration is less than 3 weeks, purulent inflammation of the mucoperiosteum of the middle ear cleft by the pyogenic organisms. If treated earlier, this disease is reversible. It is most commonly seen in infants and the children of low socioeconomic group. So, by middle ear cleft, it includes the tympanic cavity or the middle ear cavity, the eustachian tube, the attic additus, and the mastoid antrum and the mastoid air cells. Now, what is the etiology of ASOM? So, there would be definitely some predisposing factors, that is allergy, overcrowding, unhygienic conditions, poor nutrition, faulty feeding. That is, if the child is fed in horizontal position instead of slanting position, and if the child is already having immune deficiency and cleft palate. So all these are few predisposing factors to develop ASOM. It can occur in infants and children more commonly because when compared to adults, the eustachian tube in children is shorter, wider, horizontal, and straight. And recurrent upper respiratory tract infection is yet another cause for ASOM. And a pictorial description of the eustachian tube comparing the adults as well as the child. So this is the adult one. And if you see in children, the eustachian tube seems to be little straighter, horizontal, wider, and shorter. So easy for the infections to enter the middle ear from the nose and the nasopharynx. And other causes for ASOM are infections of the tonsils and adenoid, chronic rhinitis and sinusitis cases, and infections from the nasopharynx. Now, how the infection from the nose or the nasopharynx reaches the middle ear? So, the routes of the spread of infection are the first one being directly through the eustachian tube. So, in case of any adenoiditis or tonsillitis or rhinitis, sinusitis, allergic cases. So, in such cases, and also faulty feeding methods, directly it enters through the eustachian tube into the middle ear. And in some cases, it is also spread from the external auditory canal. So, from the external auditory canal, for the infection to reach middle ear, there should definitely be a perforation in the tympanic membrane. And the last rare route is hematogenous. Now, let's see what are the causative organisms responsible for ASOM. So, to begin with, the most common is Streptococcus pneumoniae, followed by Haemophilus influenzae, Moraxella catarrhalis, and others are Staph aureus, Pseudomonas, and Streptococcus pyogenes. So, since Streptococcus pneumoniae is the commonest organisms, so nowadays, if we see there is a decline in number of ASOM cases. This is because of introduction of pneumococcal conjugate vaccines in children. So those who are vaccinated, so we could see a decline in ASOM, definitely because of the introduction of the pneumococcal vaccines. Let's see the pathogenesis. Now we have seen what is the cause. Now let's see how the infection through the eustachian tube reaches the middle ear. So if you see in the initial stages, because of the block obstruction in the eustachian tube, the middle ear becomes little, there is inflammation because of negative pressure in the middle ear. So eustachian tube has got a function of ventilating the middle ears and maintaining the pressures. When the tube is blocked, there will be negative intratympanic pressure. So the air is also absorbed from the middle ear, because of which there is erythema and edema in the mucosa of the middle ear. And because of this erythema and edema, the tympanic membrane gets congested. As the infection progresses, we can see that there will be exudation of the fluid from the capillaries in the tympanic membrane and the middle ear. And after there is exudation, it is followed by suppuration, wherein there is invasion of pyogenic organisms which release pus, because of which the release of pus will cause bulging of the tympanic membrane. And later it reaches a pressure point wherein the tympanic membrane will burst, leading to the drainage of the purulent discharge out from the middle ear into the external auditory canal. In all this process, the tympanic membrane mobility is diminished. So, this pathogenesis, to summarize, it is divided into stages. So, we have 5 stages of ASOM. First one is stage of congestion or the tubal occlusion. Second one is stage of exudation or presuppuration. Stage of suppuration. Fourth one is stage of resolution. So, in all the ASOM cases, definitely these 4 stages are seen. But in some cases, rarely a 5th stage is also seen, which is stage of complications. So let us see each stage one by one. So first is stage of congestion. So in this stage, firstly there is obstruction of the eustachian tube. So because of which there is hyperemia of the mucosa with edema. And there is absorption of the air and negative intratympanic pressure. Because of the negative pressure in the middle ear, it causes tympanic membrane to retract. And at this stage, the symptoms will be mild ear pain and mild hearing loss, that to conductive hearing loss. On examination, we'll see that tympanic membrane appears congested, hyperemic, and initially handle of the malleus is seen. Later, it is seen as spreading to the periphery. So, in the initial stages, the tympanic membrane is retracted, wherein we can see the handle of malleus assumes horizontal position, prominence of the lateral process of malleus, and the light reflex, which is normally present in the anterior-inferior quadrant, it is either distorted or lost. And on tuning fork test, we definitely get a negative Rinne's test, which indicates conductive hearing loss. So let's just briefly see the anatomy. So this is the pinna, external auditory canal, tympanic membrane, the middle ear divided into epitympanum, mesotympanum, and hypotympanum. Middle ear, it's like a cube, has got 6 walls. So anteriorly we have the eustachian tubal opening. Laterally we have the tympanic membrane. Medially the oval window and round window. And posteriorly it is associated with the mastoid bone. So in the middle ear, the contents include the ossicles and also the air. And in the attic, we have the additus connecting attic with the mastoid band. So this is little bit about the anatomy. Now we'll see the pictures. So the initial stages in stage 1, PM is retracted. Prominence of the lateral process of malleus. Then we can see the tympanic membrane is also congested. So this is stage of tubal occlusion or the stage of congestion. Second will be the stage of exudation. So in this stage, what happens is because of the congestion, that is, if the eustachian tube block is prolonged, disease progresses. In that stage, what happens is the hyperemia, that is the capillaries of the middle ear, will tend to exudate. So initially a seromucinous fluid is secreted, and this leads to marked congestion, and because of this fluid accumulation in the middle ear, the patient experiences severe throbbing ear pain along with the marked deafness, headache, and also high fever. And on examination, the tympanic membrane is also thickened, congested, and may also bulge out with the loss of its landmarks. So, in this stage, the appearance of the tympanic membrane is given the term as cartwheel appearance, wherein we find a radiating leash of blood vessels from the handle of malleus. And on tuning fork test, it's again RIN is negative, giving a conductive hearing loss interpretation. So this is a stage of exudation where we can see that little bulge of the tympanic membrane with congestion and a leash of blood vessels that run towards the periphery from the handle of the malleus, giving a cartwheel appearance. The third stage is stage of suppuration. So here what happens in this stage, the pyogenic organisms invade into the middle ear, and because of which the fluid, their invasion produces purulent material. So the discharge now is mixed. It is mucopurulent discharge, and this fluid in the middle ear, it tends to put pressure on the tympanic membrane to burst. So before it bursts, there will be an yellow pressure point which looks like a nipple, and hence the term nipple sign. It's an impending perforation which may rupture, release the pus. Once the tympanic membrane ruptures, the pain decreases. So it's like here in stage of suppuration, the main symptom would be discharge, which is blood stained initially, later it is purulent. The ear pain and also the fever is reduced to some extent, and even the deafness. On examination, we find a central small pinhole perforation in the pars tensa part of the tympanic membrane, and on otoscope we find there is a pulsatile discharge which is showing intermittent reflection of light. So this sign is called lighthouse sign. And at this stage, the mastoid tenderness may also be present. The tuning fork test and Puton audiometry indicate conductive hearing loss. X-ray mastoid also would show definitely little clouding of the air cells. So the two signs that we see in this stage of suppuration are nipple sign, which indicates an impending perforation, and yellow spot. It's the localized protrusion of the tympanic membrane due to destruction of the fibrous layer of the tympanic membrane, which is because of continuous pressure by pus. So we have three layers of tympanic membrane: outer epithelial, middle fibrous, and inner mucosal. So because of the collection of the pus that is putting pressure on the tympanic membrane, the fibrous layer, it tends to get destroyed. So because of that destruction, there is a localized protrusion of the tympanic membrane in one area. Then we have the lighthouse sign where we see a small pinhole perforation from which there is a pulsatile discharge leading to intermittent reflection of light. The X-ray masters shows mild clouding of the air cells. The fourth stage, stage of resolution. So it's the end result. Here the inflammatory process begins to resolve. So the mucosal pathology also reverts back to normal. So it all depends on the resistance of the host, the virulence of the organisms, and the efficiency of the antibiotics, whether this stage occurs early or it is delayed. The symptoms of this stage would be the discharge subsides, pain will also subside, hearing is restored back, and perforation, either it is pinhole or it also would have been healed. And the landmarks that were lost in the early stages will also tend to revert back. This is a stage of resolution. Sometimes we have a fifth stage that's called stage of complications. So that again depends upon the high virulence of the organisms or the poor resistance of the host, immune deficiency state of the host. So because of which the resolution does not take place, and instead there would be extension of the infection into the surrounding areas beyond the middle ear cleft, leading to acute mastoiditis, labyrinthitis, facial paralysis, vitrositis, meningitis, lateral sinus thrombophlebitis, and brain abscess. Now, how do we treat a case of ASOM? So, firstly, um, before we go for the treatment, investigations. So, if there is discharge for a longer time, definitely we can take that discharge for culture sensitivity to know the type of organism. Thereby, we can choose the antibiotic. We can go for X-ray mastoids and also X-ray PNS to rule out any sinus and nose diseases. Um, Puton audiometry to know the status of the hearing loss. Then coming to treatment. Since it is an acute case, definitely conservative management is the treatment of choice. We have to give a systemic antibiotic should be given. Along with antibiotics, nasal decongestant, either local or systemic, antihistamines, for pain analgesics, for fever antipyretics. Oral toilet is equally important, so we need to mop the ear discharge and keep it clean, and you have to keep reviewing every 2 days. So antibiotic of choice, we could prefer either amoxicillin clavulinate combination or a ciprofloxacin or any cephalosporins, and also uh, azithromycin or clarithromycin. Antihistamines, preferably we go for a non-sedative newer generation, so levocetirizine, loratadine or fexofenadine could be preferred over cetirizine. Nasal decongestions, we go for topical, preferably xylometazoline or oxymetazoline or a simple saline nasal drops. We review the condition every 2 days, that is 48 hours. In case the earache and fever are still persisting, we have to change the antibiotic. And if we find that the tympanic membrane is still bulged, then we need to perform a small surgical procedure which is called myringotomy, wherein we incise the tympanic membrane, allow the fluid to drain, and send that ear discharge for culture and sensitivity. But if after 2 days the ear ache and fever have subsided, then we can continue the same treatment for another 10 days and review after 3 months. Suppose after 3 months there is no fluid accumulation and tympanic membrane and middle ear appear to be normal, then no further treatment is needed. But if the fluid persists in the middle ear, there is no ear pain and deafness, but fluid accumulation with mild ear block, if it is persisting, we have to treat it like an otitis media with effusion, where we have to do this procedure of myringotomy. But in case of any abscess or mastoiditis, we have to go for cortical mastoiditis. The protocol goes this way. So first, after once diagnosing it as a case of ASOM, we start off with antibacterial therapy along with other antihistamines, decongestants, and analgesics. Review after 2 to 3 days. If the symptoms are persisting, we go for another antibiotic. But if the response is good, then we continue the same antibiotic for 10 days. Then we have to review. So if still the symptoms are persisting, then we can go for myringotomy and higher antibiotics. But if there is complete resolution, we stop the treatment and review after 3 months. Mm, After 3 months, if there is complete resolution, that's fine. If there is still some fluid left behind in the middle ear, which is uh, definitely evident when impedance audiometry is done, then we have to treat it like otitis media with effusion. Go ahead with myringotomy. So, what is myringotomy and what are its indications? So, indications are whenever the tympanic membrane is bulging, there is acute pain, no relief with antibiotic and other antihistamines. In such cases, we should go for myringotomy. If there is incomplete resolution despite antibiotics being given with persistent conductive hearing loss, then we have to go for myringotomy. Persistent effusion beyond 12 weeks is another indication for myringotomy. So, what do we do in myringotomy? So, in this procedure, in ASOM, we give a curvilinear incision in the postero-inferior quadrant. The incision should be curvilinear, not radial. Radial means it is like this, exactly radial to the fibers. In curvilinear, we have to cut the fibers. This helps in keeping this opening patent for a longer time so that the fluid can drain. So it is curvilinear incision in ASOM. Small video which is showing this myringotomy procedure. Initially, under sedation, we have to take a small cotton pledget soaked in 4% xylocaine solution over the tympanic membrane. This is local infiltration. This video is showing myringotomy for otitis media with effusion. It is not for ASOM. So here we'll see that we take a micro ear instrument. We can take a myringotom knife or a simple straight pick and give a, here we are seeing a radial incision. Whereas in ASOM, we usually give like this, a curvilinear incision. After an incision is given, we try to suck out the fluid using a suction cannula. The fluid can be sent for culture sensitivity so that we can know the type of organism and type of infection. So initially it's a blood-stained discharge followed by the glue-like discharge coming out. Then we keep a tube which is called ventilation tube, goes by the name grommet. So it has got two openings which helps the opening so that the fluid gets drained through this hole. After 3 months, this grommet tube, it itself gets extruded out from that incision site. So in ASOM, why do we make an incision in the posterior-inferior quadrant only? Because it is the least vascular area, and here the tympanic membrane bulge is also maximum. Ossicles are not damaged, and it is easily accessible area. So next, acute necrotizing otitis media. Few words about this. So often it is seen in children who are suffering from measles, scarlet fever, or influenza. Here, the causative organism for this condition is beta hemolytic streptococcus. And there is rapid destruction of the whole tympanic membrane reaching up to the annulus. The ossicles also are destroyed. The mastoid air cells are also involved, and the mucosa of the promontory is also destroyed. And profuse otorrhea is seen in this condition. So in these cases, the healing is by fibrosis, and sometimes there would be secondary acquired cholesteatoma in these cases. We have to treat these cases by giving antibiotic for at least 7 to 10 days. Unresolved cases, we go ahead with cortical mastoidectomy. And then we have something called recurrent acute otitis media. By which we mean that usually the children of age group between 6 months to 6 years, they might get recurrent episodes of this acute otitis media, nearly 4 to 5 times per year. And recurrent middle ear infections may be superimposed upon the existing middle ear effusion in these. So it means, see, first they will be having an attack of ASOM. Suppose it is not resolved. The pain has decreased, but the fluid is still persisting. So it is given the term as otitis media with effusion. On top of it, again, there is a superimposed acute infections. So in such cases, it is recurrent otitis media. We have to find the cause and treat it. That is the only way how we can deal with it. We have to go for antimicrobial prophylaxis, myringotomy, and insertion of the grommet tube should be done. So we shall end this session by summarizing few take-home points for acute suppurative otitis media. So to begin with, one has to know the middle ear cleft, which is made up of the middle ear cavity, the eustachian tube, the attic adytus antrum, and the mastoid air cells. So the acute infection of the middle ear cleft by the pyogenic organisms, it is called as ASOM. So ASOM means the duration is less than 3 weeks. It is this repeated attacks of ASOM will make the patient land up in CSOM. So what happens in CSOM? There is a perforation which does not heal by itself. And ASOM compared to CSOM, ASOM is common in children than adults. And the commonest organism being Streptococcus pneumoniae. But nowadays we can see that there is a rapid decline in cases of ASOM, that is because of introduction of the pneumococcal conjugate vaccines. And we have to identify the clinical features of ASOM. The commonest cause for ASOM is, since it is seen in the pediatric age group, it's because one is faulty feeding because of the wrong methods of feeding, because the eustachian tube in children is shorter, wider, and more straighter when compared to adults. And recurrent respiratory tract, upper respiratory tract infections, tonsillitis, pharyngitis, immune deficiency states. So predisposing factors are definitely there. Like if the child is in a low socioeconomic group, overcrowding areas, faulty feeding techniques, allergic rhinitis cases, and sinusitis cases. So these are all few predisposing factors in whom ASOM is very common. The route of spread being eustachian tube. And then we have to identify the 5 stages of ASOM, which is very important. Stage of congestion or tubal occlusion, stage of exudation or presuppuration, stage of suppuration, and stage of resolution. In few patients, we also see stage of complications. So we have the cartwheel appearance, and then we have the nipple sign and the lighthouse sign. So these are the 3 signs that we see: cartwheel appearance, nipple sign, and the lighthouse sign, which is the lighthouse is the pulsatile discharge. So initially it is a throbbing ear pain, and as it goes to the stage of suppuration, once the discharge comes out, the pain subsides. Stage of complications, it extends to the surrounding areas like mastoid, there can be facial nerve palsy, and labyrinthitis, involvement of the inner ear, and also meningitis and brain abscess. Then coming to the treatment aspect of ASOM, we have to manage conservatively. Ear oral toilet or mopping of the ear discharge is very important. And every 2 days or 48 hours, we need to do follow up. Look for the reduction of the symptoms and also the signs. So we give antibiotic, antihistamines, decongestants, and and also go for steam inhalation. So if there is after 2 days, if there is complete resolution, that's fine. We continue the same antibiotic. If there is no resolution, then we have to go for a higher antibiotic. But if the pain is very severe and tympanic membrane is bulging out, then definitely there is a need for a surgical procedure called myringotomy. So myringotomy again, it is for ASOM, we give a curvilinear incision in the posterior quadrant. Whereas in otitis media with effusion, we give radial incision. So, as said earlier, so 48 hours we have to do the follow up, and after 48 hours, if the treatment has uh, perfectly been given, patient has responded well, then we need not go for myringotomy. After 3 months, we have to review the condition. If it is persisting fluid is there, then again we go for myringotomy followed by the chromat incision. So this is about ASOM. And if suppose ASOM is not treated, then it can lead to CSOM. So if ASOM is left untreated, it leads to recurrent attacks of ASOM, which can make the patient land up in CSOM, where there is a permanent perforation in the tympanic membrane, which definitely needs a surgical intervention. We have to go ahead with a procedure called tympanoplasty, taking a graft which is harvested from, that is the temporalis fascia. So I hope ASOM is clear in this learning session, hopefully. Thank you.